Respected chairpersons and distinguished members of the audience, I thank the organizers for this opportunity to be here today, and really very interesting to go through all the posters outside and see all the new developments coming up. So I will be speaking on role of HPV vaccine in the prevention of carcinoma cervix, and my task has really been made very, very much simpler by the excellent presentation by Dr. Bhatia, who has really set the stage. I've worked with both the vaccine companies, and so we go through how it's still a major problem, and we'll just briefly go through whatever needs to be covered regarding the EPI with respect to the role of the vaccination and the results that we already see, and the safety and efficacy, which is actually the most important concern in this country for some time now. So we've already been through this, where 1/4 of the global burden, both in terms of incidence and mortality, is in India. But apart from HPV causing cervical cancer, for which it is almost 100% responsible, there are several other cancers which have been shown to be attributable to HPV. And the red shows the number which are HPV attributable, and the white shows the total number of cases. So you can see that in case of the cervix, it's 99.7%, they say, so almost 100%. A large proportion of the anal cancers as well. And apart from that, the oropharynx is important. The vulva and vagina in gynae terminologies is important, but aside of the fact that only about 40% are contributed, these are cancers which are relatively of lower prevalence, but more and more in the head and neck as well, and we do know that they have a better prognosis when those ones are HPV related. So we have more than 100 HPV types, and about 40 of those are known to be associated with the anogenital tract. And these can be further subdivided as the high-risk oncogenic and the low-risk types, both of which are actually relevant in clinical practice. And both of them are important because while the high-risk and the oncogenic are important in terms of mortality, even the low-risk cause significant morbidity, and the implications which were also being discussed in the breast cancer talk of immense psychological and other overlays. So in these cases, the prevalence of HPV, because it is a virus that does not generate much of a reaction and a response of an inflammatory type, and in many cases does not go through the basement membrane, only about half the people who actually have an HPV infection will mount a serological response at all. So this is a situation where people may have the infection but just be completely unaware that they carry it, or that they are in the potential of infecting a partner or other people with it. So you may have a situation ranging in the high-risk types from no clinical changes to CIN1 to cancer precursors, that is the high-grade cervical intraepithelial neoplasias, and then the cancer itself. And in the low risk, it is more likely to lead to the CIN1 and the genital warts, which I said is a tremendous burden, both physical treatment-wise as well as the psychological implications-wise, and a situation of respiratory papillomas, which are sometimes encountered in the newborns, the laryngeal papilloma, and some cases are reported to progress on in those as well to be associated with malignancies. So there are several clades, as it were, that they are divided into, and I know you can't see this from behind, but as the clinical persons go, we are really mostly concerned with the A9 and the A11, which are the ones which are causing the gynae diseases, and then there are some related ones. So you see here that they are originating from a common sort of a background. So there is a relationship between the 16, 31, 33 as we see it here, and in the A7 with the 18, 45, etc. And this is possibly the reason why we find that there is some cross protection that is offered by these vaccines, which have been developed against even the HPV 16 and 18. And we've already seen this working model, so to speak, of the cervical carcinogenesis. And it's something which has been known for a long time to gynecologists, because the good thing about the cervix is that you can easily visualize it. You can easily sample it. The most important reaction the cervix has is to dilation, which is the pain. But you can actually burn it and freeze it with minimal discomfort, which is why the screen and treat procedures are workable, which were discussed, because the patient really is fairly comfortable with no or little local anesthetic. So this is something which we've known for a long, long time from epidemiological observations as to what is the nature of the natural history of cervical cancer. And it is only now that we've got this interposition of the HPV infection, which typically comes depending on the sexual behavior of the self or the partner. The majority of them revert within an average period of 8 to 12 months. And this is brought about by the innate immunity as well as antibodies and cytotoxic T cell responses. But there will be some who will persist. And typically this is about 10% of women aged over 30 years. And that is why the HPV test is recommended to be done after age 30 years, so that those who had to clear will clear off by then. Otherwise, you would have a large number of positives without getting results. And this is basically also related with immune suppression, as maybe with HIV or renal transplant cases. There is some feeling that HLA types may be involved, though very little influence there. And perhaps the viral types, the viral load, and the viral variants may all be responsible in determining which of the women are going to persist. And then other behavioral factors like smoking or parity, or perhaps even the long use of OCs and inflammation lead to the high-grade neoplasia. And eventually you have some molecular events which lead to the invasive cancer. So the various tests that can be done for this have been discussed, and it has been seen that for us, it doesn't work really to have this screening, which everybody thinks should be the way to go, but just isn't working because there is such a low coverage of screening in our country. And therefore, we have a situation where we have the role of the vaccine to interrupt this right before the acquisition of the HPV vaccine. And so you have this prophylactic HPV vaccines developed, which are based on empty virus capsid. So they are the virus-like particles which recombinant and produce a high titer of neutralizing antibodies. And so we have the two vaccines that are currently available worldwide and licensed in India. And there is a minor difference in terms in these, well, minor or not, I don't know how you look at it, because in terms of the cervical cancer, they are pretty similar, 16 and 18, but the Gardasil quadrivalent contains in addition 6 and 11, which are responsible for 90% of votes. The adjuvants are different. The GSK has a proprietary adjuvant called ASO4, which produces a much higher antibody result, and is thought to sort of also be the reason why people receiving this vaccine have more reaction at the local site. But both of them are 3 doses, fairly similar, 0, 2, and 6 months, 0, 1, and 6 months, given as an intramuscular deltoid injection. So the 16 and 18 were essentially picked up because this is the majority worldwide, give or take a little bit. Average 70% of cancers worldwide are related to HPV 16 and 18. In India, in various studies done around the country, which have been included by the WHO ICO in their analysis, we find that the HPV prevalence overall is about 8% amongst women with normal cytology, and the cervical cancer contribution of 16 and 18 at 82.5%, so much greater than the average. And this is something which Dr. B.C. Das has always been saying from the first studies that he did, which were not necessarily comprehensive and testing for all HPV types, but he always showed that HPV 16 was there in a large proportion, even as many as 90% in some of his work. So we do know that these vaccines are very, very good for our population and completely suitable. And if we go by the 82.5%, and we actually expect some more degree of cross protection, it says that the majority do stand to get prevented. And we'd done the immunobridging study in which we'd taken 330 women, which was essentially the licensure study, and we did it in these healthy, non-pregnant women. And we found this very great response. So this is the amazing thing about the vaccine, is it generates such a brisk response. These are in log titers, so you can see that the placebo group, both for 16 and for 18, has very low levels as compared to the much higher titers which are achieved, and almost all patients will seroconvert. Even in the larger trials, about 98% did seroconvert. So we do have both of them available. We have the infrastructure for the vaccine administration with the EPI vaccines, because you do need a cold chain for these vaccines. And we do expect that we can have a good result. The Cervarix bivalent vaccine has now followed their cases for about 9.5 years, and they find that the first and highest response is at 1 month after the third dose, that is at 7 months, gradually settles by 12 months, and is more or less proceeding in a plateau. So it is kind of expected that it will be like the hepatitis vaccine, where we may not require to give a booster, but if, of course, only time will tell, but mathematical modeling is now suggesting that it will not be required. Furthermore, because these trials were done in women aged between 15 to 25 years, so they did these immunobridging studies with younger girls, and they found that they have almost 2 to 3-fold of titers as compared to, and that is typical for any vaccine. You will get a brisker response the younger the age of the participant. This was the data from Gardasil, which they published, and they found that they actually had a decline in the 18 titer. The 16 titer continued to remain high as compared to the placebo, but the 18 came down considerably, and this caused a lot of concern. But so far, the efficacy data has not shown a problem with this. And so a lot of you here are the basic scientists, and I'm sure you understand even better than me that there are other mechanisms of immune response. There are concerns about whether this method picked up all the antibodies at all or not, about the memory B cells and how they are working. But so far, efficacy has not been shown to be impacted by this falling titer. And so we have to kind of be in a watch and wait situation whether we need to give a booster at all. Certainly, as I mentioned, the ASO4 has shown a much brisker response in the antibody levels as well as in the memory B cell pool. And the correlation between the serum and cervical mucosal body also has been shown to be directly correlating with the titers in the serum. Regarding the efficacy against CIN2 plus related to HPV 16-18, the vaccine types with both the vaccines is excellent, about 98%. And so if we take this, because it's a long time frame for one thing, and it will take almost 15 to 20 years to prove that it did not cause cervical cancer. And the second point is that it's actually now unethical not to treat a patient who has a CIN2 or 3. So for both these reasons, you cannot actually expect to compare cancer outcomes in a trial group. You can only expect to eventually compare cancer registry data before and after. But what is looked at is the prevention of development of new infection and the prevention of CIN2 and 3. So, as I said, both of them have shown some protection against other vaccine, non-vaccine types, 31 and 45, to a variable extent. And this is again with the Gardasil. But there are barriers to implementation of vaccination in India. There's lack of awareness. There's misinformation to a large extent on safety and efficacy. Many of you may be aware that the trials were kind of interrupted because there were concerns that deaths had occurred because of the vaccine. However, the committee has submitted its reports. The deaths were far removed from the vaccination, more than 1 month away from the time of vaccination in almost all except one. And because of completely unrelated causes like snake bite and drowning and poisoning and cerebral malaria and viral fever. So the committee has already sent its report, which is yet to be formally cleared by the ministry, of course. There are issues of cost, but it is now a Gavi-approved vaccine, the Global Alliance for Vaccines and Immunization, which means that Gavi has negotiated a rate of $5 a dose, which is a very good dose. And for countries in the lowest income brackets, it will probably cost about 20 cents a dose to them, but we are not in that in any case. We are in the lower mid-income group. The logistics of the cold chain, as I mentioned, we do have the facility for EPI, but yes, the challenge is to produce vaccines which don't require cold chain, and I think there are groups which are already working on the capsomere vaccines which will not require a cold chain. The logistic difficulties in accessing the pre-adolescent and adolescent girls who are not really within the frame of the pediatrician and nor exactly of the gynecologist. They're kind of in that gray zone. So there is now some effort to look at the titers and to consider giving the vaccination to even younger girls. But there are some issues because some parents don't like the fact that you give a vaccine which is going to protect against something which will be relevant only when they're sexually active. Having said that, most studies have shown that parents don't really believe that the girls will become more promiscuous because they've taken a vaccine. And I think also that it is kind of analogous to saying that people will become promiscuous because people will become rash drivers because they're wearing seat belts. So I think that is kind of a little bit shown by various studies not to be relevant. But yes, challenges in compliance to a multiple dose regimen are there. They've been shown with EPI as well. And we are presently in an IARC study for a 2 versus 3 dose trial, and the preliminary results, I can tell you, are very exciting and show almost complete parity between the 2 doses given at 0 and 6 months, not at 0 and 1 or 2 months, but at 0 and 6 months. And there have been similar results coming already from British Columbia and other studies. So I think this will soon work out. And already I mentioned about the socio-cultural barriers briefly. The safety, which has been so much concern. So you see, whether you look at medically significant conditions or new onset chronic disease or new onset autoimmune disease or serious adverse events, they are really pretty similar between the vaccine versus placebo groups. In fact, in some cases a little bit less, but essentially statistically insignificant. And the kind of problems that you see are really very, very common in the general population. So they are not increased at all by this. And even in the AEs following Gardasil from the registry, which documents post-marketing, there was nothing which was very serious except the syncope. And because it can lead to serious outcomes, they recommend that you must give it with the girl or the woman lying down and not sort of let them go away immediately, especially with young girls who are very prone to giddiness anyways. But there was no clustering by age groups or onset intervals or dose number for the deaths, and no trends in clinical conditions that preceded or caused deaths. So the WHO and CDC concluded that the safety profile is similar to that described in the RCTs, which already had very large databases of 16,000 women each. But more recently, there's been a study published which was sort of sought by the US government themselves on the short-term side effects, in which they followed 190,000 girls almost for 6 months. And they found that they were 6 times more likely to faint and about twice as more likely to have a skin infection. And aside of that, there were no things. So generally concluded that it's safe. But of course, if you're looking for something which is really, really rare, then it is difficult to find a study that can get adequate power to really measure that. But as of now, there's nothing absolutely which has been shown to be more common. So just a very briefly about a very exciting new information that is forthcoming, because as I said, they've been concerned about the outcome measure, and you're just looking at the development of warts or CIN, or actually just looking at HPV infections or CIN, and is that really good enough to tell us about cancer? But certainly now we have information from Australia, which was the first country which sort of put this into their national program. It was because their Prime Minister's wife came out and said that I have suffered cervical cancer. Nobody really knew that till then, but she came out and said it, and Ian Fraser, who developed the vaccine, was from Australia. So it was put into their program on a very fast track, and they gave all girls 12 to 13 years of age. And for 2 years, they actually gave it out to the GPs as well, to give everyone till 26 years of age, which was their license at that time. And then they took retrospective analysis from their warts register for the whole period from 2004 to 2008, and they looked at the pre-vaccine and the post-vaccine. So they had about 36,000 patients whom they looked at in this time. And they found that of the women who were eligible for this free vaccine, the red shows the residents and the green shows the non-residents, and they found a significant decline amongst the women who had been vaccinated in this period. And they looked at the heterosexual men as well, and again they found that there was a considerable decline amongst the men who were 26 years or younger as compared to the ones who were over 26 years of age. And so here you see effect of herd immunity coming in as well. And in fact, what has even been published after that is that they looked at the men who have sex with men, and they did not see a decline in that group. And this data has now supported the introduction of the vaccine for men, for boys, I should say, in Australia and New Zealand, which is now starting free vaccination for the boys as well. And looking at the women, there's been this evidence that you have the women under 18 years of age, the font is a little small, I'm sorry, 18 to 20 years, 21 to 25 years, and 26 to 30 years, and this should be showing on all the years going from 2003 to 2010. And you see after 2007 where they had the vaccination here, and you can see the decrease in the high-grade abnormalities in these girls who have been vaccinated at the time, and some decline as they grow a little bit older, but nothing seen in terms of declines. It's not as though they're declining everywhere, but they decline among the girls who got. So if we accept that this is a precursor lesion, we must accept that we will have encouraging results. So in conclusion, can I just get the conclusion slide one sec? Yeah. Secondary prevention has not yielded the desired results, and HPV vaccination is an important complementary strategy of primary prevention. The safety and efficacy data indicate considerable benefit to risk ratio, so we must clear the misconceptions and improve awareness among the population at large. And with that, I thank you for a very patient hearing.
Is there any questions from the audience? Yes, please.
I think you addressed a very important point in terms of awareness and how to take it to the subjects who will be vaccinated. How much effort? I mean, I think this is more in the realm of primary care or extension type of. I mean, you have great clinical as well as biological foundation, and India being, in the field of vaccination, there has been so much success that this should be could be much easier than any other thing. Will other cancer strategies will be pushing in terms of the awareness. So I'm just wondering, how much effort is going on government-wide or at the lower level, because specialty hospitals, they do deal with it efficiently.
Yeah, unfortunately, although we have a national cancer control program, but we really haven't seen the kind of thrust that we should. And at some point, because health becomes a state subject, there are a lot of issues involved. And the vaccine, as I said, just came under a cloud because of this misrepresentation, as I perceive it, of the situation, because really there is no scientific evidence at all that we have any problem regarding safety or any concerns that our girls are any different in terms of response from the others. So at this time, we do see some promising efforts at screening in some of the states, and Tamil Nadu particularly has taken a lead in that direction to bring the VI program into their district program and expanding it now. But as far as vaccination goes, we don't see that kind of a thrust at all at this time, and I'm not sure if we will ever see it on our priority list in the near future.
I have a question. Yeah, great presentation indeed. I just want to know from you, you mentioned the 6 times higher incidence of having syncope.
Syncope.
How long does it last?
No, it typically does not last for more than 15 minutes, and therefore...
6 times incidence, how many years?
No, this was a 6-month follow-up of them, so there were 6 times more common the syncope than you would see it amongst people who were just getting injections for other reasons in the hospital.
Well, any other question? Yes,
it's an excellent talk, Dr. Bhatta. I have one question. Question is regarding, I would like to know, how long did you follow up for the Gardasil and Cervarix, the titer they are lasting?
The study that we did in India, we just did the follow-up at, we did it at 0 months and 7 months, and that was it. Okay. We didn't follow them up further. Okay. But the studies that were done on the original Patricia and all those ones, those have continued for about 9 months, because ours was basically for the licensure.
Okay, only for licensure.
So now the one which we were doing, the 2 versus 3 dose, that it was originally planned as a 20-year study.
Right.
But let's see now what happens. We are following up those, and it's really very encouraging to see with the different doses how it is coming forward.
I am from the Institute of Cytology and Preventive Oncology, that is a ICMR Institute in Noida. We supposed to do the multi-center clinical trial for Gardasil, okay, but because of the incidents in Andhra, time being it got postponed and inquiries ongoing. So that is the reason Indian Council of Medical Research didn't take up through proper channel, so it is still under investigation.
Yeah, but having said that, other trials are going on in the country and have been done even on HIV population, all which were under the DCGI. So it's not as though HPV vaccine trials are halted forever.
Still going
Yeah, at a lower pace.
Yes, please.
For past many months, many years only, that I have attended so many conferences and workshops, and these are like current topics, that what should be the best screening test, especially in low resource setting like India, and whether the vaccine is effective or not. So I just want to know that every conference, every workshop, the conclusion is that VI is far better, VI is cheap, it can be used, and it is very effective, especially in India where the infrastructure, we don't have the lab and all for the pap smear. Yeah, as you told that. And as ma'am said, that vaccine is very effective. So I have two questions. That when we all know that VIA is better than PAP and vaccine is effective, then why are we not incorporating this thing into our system?
No, I would like to.
No, that is okay. But my question is that when the vaccine is so effective, why don't we incorporate it into our vaccination schedule as the Australia?
We should. You're right, we should. Maybe we will sometime. Actually, the FIGO, the International Federation of Gynae now has a new slogan coming up, which is screen all women by age 40, vaccinate all girls by age 15. With the combination of those, you should work. And I think that even eventually it will turn out that even 2 doses and maybe even 1 dose offer some protection. So 1 dose of vaccine and 1 round of screening might work to reduce substantially with a burden like ours. But I'd like to correct one concept, which is that VI is not better than PAP. In low resource settings where you don't have PAP, the VI sensitivity is equivalent to PAP. But VI has very poor specificity. If you go out in the population, 15% of women will be VI positive, whereas hardly 2% of them will have disease. So there is a huge problem about who is going to triage those women, who is going to manage them, which is why the program hasn't taken off.
Actually, I had my thesis on comparing PAPsmear with VIA. Even I had the similar results, that PAP had better sensitivity and VI had better PAP had better specificity,
right,
and VI has better sensitivity.
So hopefully Care HPV might prove to be our answer if we get an affordable test. Then you will have lesser numbers to deal with.
But I think I have an opinion that since VI, according to our screening test, it should have a better sensitivity. Means it should not miss any lesion. Then when VIA has a better sensitivity than PAP, then why don't we use VIA first and then?
Yes, we should do that. We should do that.